Welcome to this series of interviews with the giants of cardiac surgery. My name's Joel Dunning and I'm here at the STS conference in San Diego with Professor Duke Cameron. You're cardiac surgeon in charge of Johns Hopkins and you've been there for over 25 years. You've worked all around the world, including Cairo, Cuba and Saudi Arabia, operating even on people that couldn't afford it and would have died without your help. You've got one of the biggest series of Marfan's patient root replacements in the world, and that's what we'd like to talk about today. We'd like to get the hints and tips of what makes a good root replacement in Marfan's patients from you and go through that. And maybe at the end we'd also like to hear sort of what you do in dissections in Marfan's. But before we do that, I wonder if you could just go through your criteria for which patients should come to aortic root replacement and what you tell a patient that maybe only has a 5.1 centimetre root with Marfan's.
Right. Well, first of all, Joel, thanks very much for the invitation to be part of this project, which sounds very exciting, and I'm really honored to be part of it. We do have a large experience with Marfan syndrome at Johns Hopkins, and it actually dates back to the time of Helen Taussig, who wrote one of the first papers about aortic aneurysms in Marfan syndrome. Most people don't realize that she was one of the reasons that our large clinic got started at Hopkins. But there was a great interest in the problems of aortic catastrophe, rupture of aneurysms, dissections occurring in the Marfan root, which has a peculiar and unique pattern of dilatation. Typically, the Marfan aorta dilates really only at the sinuses. It's unusual for it to dilate anywhere else in the absence of a dissection. So the problem seems to get started in the root, and dissections or ruptures typically occur, interestingly, not in the root, but just above it. And then if a dissection occurs, a so-called type A is the most common in Marfan syndrome, then the cat is out of the bag and it becomes a very high-risk operation, as aortic dissection repairs are in all patients. And the mortality rate in the 1970s at our place, when we operated just for dissection, was close to 50%. And Dr. Vincent Gott, who really began our surgical program in Baltimore in the 70s, was very impressed by the report from Mr. Hugh Bentall at the Hammersmith Hospital in London about this new technique of replacing the aortic root prophylactically, replacing the sinuses and the valve. And he and Dr. McCusick, who is our geneticist who began the Marfan clinic at Hopkins, thought that if there was ever going to be a chance to intervene with good results and low operative risk, we had to do it prophylactically. And of course, at that point in the 70s, we didn't have good data on the natural history of this. So they somewhat arbitrarily chose 5.5 centimeters as the time that the aorta should be replaced prophylactically, based a little bit on some data perhaps from abdominal aortic aneurysms. So in 1976, we started a program of prophylactic aortic root replacement when the aorta reached 5.5 centimeters. I will say that over the years, as our experience has grown and our confidence in the safety of the operation has grown, the threshold for intervention has come down now to about 5 centimeters. I know there are a lot of groups saying that it should be 4.5. I think it's a bit of a slippery slope once you start lowering thresholds simply because the results of your surgery are so good. If you have a 0% operative mortality and you take that reasoning to the extreme, you're suddenly replacing a lot of normal aortas. So we think that in the real world, a threshold of about 5 centimeters is probably about right, where the operative risk is going to be well below the risk of the natural history. We do lower it if there's a strong family history of rupture or dissection. We'll often do it at 4.5 centimeters. And then, of course, if there are valve lesions, severe aortic regurgitation, which is actually a bit unusual in Marfan syndrome, then we might lower the threshold in that setting too.
And your threshold is even lower in some other connective tissue disorders, isn't it?
Yes, one in particular, Louise Dietz syndrome, which is a disease described by one of our geneticists, the one who inherited Dr. McCusick's practice, Hal Dietz, working with a Belgian geneticist, Bart Louise, described a group of young adults and children with a syndrome that looks a little bit like Marfan syndrome, but it's really not the same. Much younger patients, and they have aortas which are more likely to rupture or dissect at much smaller diameters. So in that group of patients, we usually recommend prophylactic root replacement when the aortic sinuses are greater than 3 centimeters in children and 4 in adults. It's not based on a lot of data, I must tell you, but there's no question that the risk of rupture and dissection is much greater in that disease than Marfan syndrome. It should have a lower threshold. I'm sure we'll refine this as experience grows.
And you even see some Ehlers-Danlos patients as well, don't you?
We do, but not too many. You know, fortunately, it's a very rare disease.
And so we're going to take somebody to theatre. The aim in the modern era, I suppose, is a valve-sparing root replacement. Are there any patients where you go, well, we're not going to be able to do that, we're going to have to replace this valve?
Well, you brought up a good point, and I'm always quick to say that the Bentel operation is still the gold standard operation. It's an operation that's been around for more than 40 years. It's one of the most successful operations in the history of cardiac surgery in terms of the low operative risk, the benefit that the patient enjoys, and the durability of the operation. I don't know many other operations that have a track record like that. So it's a good operation, but for some patients, having a prosthetic valve, whether it's a bioprosthesis with limited durability or a mechanical valve that requires anticoagulation, for some patients, those options are less attractive than the operation to save the valve. So there's been a lot of interest in the last 15 years in valve-sparing procedures, and we think it's a good option for young people. And to answer your question, though, are there certain patients who should not have a valve sparing? Well, I think one answer is yes. A patient who is likely to have a bioprosthesis last a lifetime, so this is an older patient, it's not usually a Marfan syndrome patient, I think a bioprosthesis is a more reliable and safer operation in most surgeons' hands. But young people are usually the people we're operating on in these connective tissue disorders. And for them, I think saving the valve makes good sense, even if it's not a lifetime solution. 20 years without anticoagulation or 20 years without a risk of reoperation for bioprosthetic valve failure is still a good outcome.
So let's get into theatre. Let's start the operation. Before we get into the route, obviously we've got to cannulate. And do you have any good tips, and where do you put your cannulae?
Well, I will say, first of all, there was a lot of concern early on that cannulating the aorta directly was problematic in patients with connective tissue disorders. In the early part of our series, they all had femoral cannulations, but halfway through the series, we realized that really wasn't a concern. And so the aorta can be cannulated directly. How far one goes out depends on how much of the ascending aorta needs to be replaced. Does the proximal arch need to be replaced? And for Marfan syndrome patients, it's fine to cannulate the aorta directly near the base of the innominate artery. We don't replace the entire ascending aorta or arch prophylactically in Marfan syndrome. So cannulation, the proximal arch, and then clamping nice and high at the base of the innominate, I think, is sufficient.
And just a 2-stage venous cannula or bicaval?
We use a bicaval, and it's just an idiosyncrasy of mine. I think it comes from my background in congenital heart surgery. I love bicaval cannulation. I think it drains the heart better. It keeps the right atrium emptier, and therefore less warming from the systemic perfusate. But I look for a patent foramen ovale in every patient that I operate on who's on cardiopulmonary bypass. Mm-hmm. We have some data to show that the TE is is not terribly reliable for ruling out PFOs. So if we're cannulated and we're on bypass, we just open the atrium real quickly and close a PFO.
So you open up to have a look?
Yes, it doesn't matter what the TEE shows because it's wrong half the time.
In all your root replacement patients or all your patients?
Actually, all of the patients, yeah.
Okay. What percentage of the time do you end up closing one then?
It's a third of the time, which is what the autopsy series would suggest. That is the incidence of PFO. But the point is, you cannot rely upon it. You cannot rely upon a TEE to tell you. And this is a digression, but the real reason that I push this is that I'm concerned about paradoxical air embolism as a cause of stroke and neurologic dysfunction after bypass surgery. We all see how much air ends up in the venous side. We all see those little bubbles of air in the innominate vein when we open the chest, because the anesthesiologist often is not as careful about air as we are. And we also have done a study to show that our left heart endocarditis patients, where we're replacing the aortic valve or mitral valve, the incidence of PFO in those patients is twice as high. It's 2 out of 3. So I think it may have something to do with left heart endocarditis. And so if we're putting prostheses or valves on the left side of the heart, I think it's important to close that PFO.
Okay.
So that's a long-winded answer for why we bicavally cannulate. The other advantage is that with bicable cannulation, the superior vena cava cannula, when it's put in through the atrial appendage, actually helps hold the right atrium down away from the root. So it improves root exposure. The two-stage cannula kind of comes up from the IVC, and then it has to turn around, and it actually, I don't think it exposes the root as well.
And venting, to use a right superior pulmonary vein vent?
We do, and it's a short vent. It's really not a left ventricular vent. It's just a left ventricular or left atrial sump, actually.
Okay, and in terms of your cardioplegia, do you antegrade, retrograde, or just antegrade?
I'm a big fan of antegrade, and we give one dose and then repeat it about every half hour, and we rely still very heavily on the old Shumway technique of topical cold. We actually run it continuously over the heart.
Yeah, do you cool down a bit or stay?
Usually about 28 degrees for a root, sometimes 30 if it's a bigger patient.
Okay, so we've cardioplegia and we're ready to open the root and prepare the root. So do you want to talk through your technique for how you do this?
Sure. We've got some slides here that I think will demonstrate this. And this first one shows the surgeon's perspective. It doesn't show the cannula in place. But our first step is usually to clamp the aorta, arrest the heart, and then transect the aorta about a centimeter or so above the sinotubular junction. And then the aortic root is rotated forward. And I think the dissection at this point is one that people don't talk about as much, but I think it's really important to improve the exposure of the root. And I don't really have good slides of this, but there is a frenulum of tissue that hangs down from the inferior wall of the right pulmonary artery that attaches the back of the root to the right pulmonary artery. And if you take the cautery and follow that inferior margin of the right pulmonary artery all the way around down, essentially to the pulmonary annulus, the root will actually rotate forward and up, and it makes the exposure of the root much, much better. So after we take all of that frenulum down, and by the way, if you stay right onto the inferior border of the right pulmonary artery, you won't get the left coronary. If you get too close to the root, you'll get too close to that. Just hug the right pulmonary artery. We then rotate the root up, and usually we'll place 3 sutures of silk at the tops of each of the 3 commissures to hold the root up and orient it for us. Now, all of the angst over this operation is choosing the graft size, and we've tried various formulae and measuring leaflet length and so forth, and I haven't really found that terribly useful. But what I can say is that if the aortic valve is working well at the beginning of the operation, and if it's closing the way it should, we call this the position of prayer. The aortic valve should close this way, not like this, and certainly not prolapsing down. But if it closes like this, the forces of closure are dissipated appropriately on the leaflets, and there's not an undue or pile driving force to push the leaflets down. So if the valve is closing like this, then what you really want to do is preserve the diameter at the annulus at the bottom and at the sinotubular junction. And that's the way to think about it. So if the valve is closing the way you like, then with the aorta transected, you measure the internal diameter at the sinotubular junction with a valve sizer. And then you add about 3 or 4 millimeters to that, because the graft that we're going to put in is actually outside the root complex. So measure the internal diameter at the sinotubular junction, what we would call the optimal sinotubular junction diameter. Add 3 or 4 millimeters, and that's your graft size.
Do the sizes vary quite a lot, or would you say you most often use one certain size, 28 or something? Or?
Well, if you operate on children, it's going to vary quite a bit. In adults, I would say that an average size non-Marfan patient, it's going to be about a 30 millimeter graft most of the time. With Marfan, it's either a 30 or a 32, depending on the size of the patient. So if you're having trouble measuring and having trouble making a decision about it, I would say choose a 30 or a 32. And if you're even having trouble deciding 30 and 32, make it a 32, because you can always plicate it down.
Okay, so err on large rather than small.
Err on large, yes.
Yeah. Okay, so we've got our stay sutures in each of the commissures, and making the coronary buttons. Is there any?
Well, before we even make buttons, we want to finish the mobilization of the root, and you'll see this on the video that there's a lot of dissection that needs to be done, particularly in the non-coronary sinus. You want to dissect on the outside of the root all the way down to a point below the level of the annulus, because the graft has to sit around the valve, and the lowest part of the graft has to be below the lowest point of the annulus. So along the non-coronary sinus, there's a lot of dissection to be done to free that up. In the right coronary sinus, there's often that muscle of the right ventricular outflow tract, which can be problematic. There's some hearts where the right coronary sinus and the portion of the annulus there are really sunk well down into the heart, and it's very difficult to get all the way down and to a level below the annulus. And we actually had to abort valve-sparing procedures in a couple of those because we couldn't guarantee that the graft entirely encased the native valve. If you don't do that, you won't have annular stabilization, and that's an important part of this operation in Marfan syndrome.
And it's one area of concern, isn't it, how far you go down around
Yes.
the root?
Yeah, and I'll also mention one other caveat is that as you're dissecting anteriorly in that anterior commissure between the non-coronary sinus and the right, that in children and small patients, you need to be careful with the use of the cautery. You're actually quite close to the AV node there, and the only pacemakers that we've had to put in about 280 patients who had these valve-sparing procedures were in children, and we're convinced that it was a cautery injury, an electrical injury to the AV node, because it was only a few millimeters away. So in small patients anteriorly, be careful about the cautery there.
How do you know when you're far enough in the root?
By comparing it, looking inside the root and seeing where the annulus is. So ideally, you want to get below the level of the annulus all the way around. And the left sinus, you don't mobilize that until you've harvested the left coronary. Yeah. So at this point, we really would then excise the sinuses. You start with the non-coronary because you don't have to deal with the coronary, and it'll open the root up for better exposure. We find it easier then to do the left coronary, and we start with fairly large buttons. It's a balance between taking too much from the aortic side. That is, you want to leave the aortic annulus and about 4 millimeters of the sinus remnant, so you'll have something to sew to. And you want to have at least 3 millimeters or so around the coronary, so you've got something to sew to. So we mobilize the left coronary artery, and then there's a dissection also shown on the video where you free up the left coronary from the aorta down low, but the dissection has to stay on the aorta if you come up under the coronary, you'll buttonhole it underneath. So at that point, we've mobilized the left coronary, then we do the right, and make sure that we've dissected around the root to a level below the annulus all the way around.
So, as you can see by the picture, we've got the commissures and we've got the buttons ready. So next, I suppose we're ready to put in some sutures below the annulus. What sutures do you use, and you pledget them, do you?
We do pledget them, and it is a 2-0 Tevdek suture. We used to do it without pledgets, but we had one patient develop a fistula along that suture into the atrium in the non-coronary sinus. So we think probably in the connective tissue disorder patients, we should make it pledgeted. And our technique is a simplified one where we only put 3 subannular sutures in, and they're put at the nadir of each of the 3 leaflets. You can put more in. David's original technique has a whole row of them that go around, anywhere from 9 to 12 or 15 of these sutures. And it's fine, you can do that. We just feel that it's not entirely necessary, since that's not the hemostatic suture line. The purpose of the lower suture line is just to hold the graft down, to make sure that the graft comes down and completely encases the entire aortic valve complex.
Yeah. And just obviously we're suturing, and what's your favoured type of graft? And I think you used the DePaulis Valsalva graft.
We've used the DePaulis graft really exclusively since about 2002, which is when it became available in the United States. And we use it because it simplifies the operation, and because we think that preservation of sinuses is probably going to be important. There's plenty of experimental data to suggest that stress on the leaflet is less if you preserve sinuses. And I'm always quick to add that still some of the best long-term results of valve-sparing root replacement have been in patients who had straight Dacron grafts. So having a graft without sinuses does not preclude a good long-term result. But I think it makes sense to try to preserve sinuses. There's a reason they're there in the first place. And the Valsalva graft has proportions that are just right for almost all of the patients. The sinuses, when they're under pressure, the sinus portion of the graft is about 20% larger than the diameter at the annulus or the sinotubular junction, and the height of the sinus portion of the graft is the same as the diameter. Those ratios work for almost all of the patients, and it saves you the steps of having to do a lot of plicating sutures all over to narrow it down at the bottom or the top, depending on which technique you used. But we're wedded to the technique simply because it's simplified the operation. And I think it also helps me conceptualize what we're trying to do by just having those 3 sutures at the bottom, and then, as you'll see, the 3 sutures at the top that fix the commissures to the sinotubular ridge.
Yeah. And how exactly do you position those commissure sutures?
Well, again, that's the beauty of the Valsalva graft. There's no thinking or measuring. You just put them at the sinotubular junction. It always feels like it's a bit of a stretch, and that's how it should feel as you're tacking them in. I think what happens is that once the graft is under pressure, these commissures sewn up to the top of the graft actually kind of pull the sinotubular ridge of the graft down a little bit, and then it bulges a little more. So in that sense, it's kind of self-adjusting, and it just speaks to the fact that the proportions of the graft, I think, are right for the majority of patients. So you don't have to do a lot of measuring and guessing.
Right. So you've got your commissures in, you've got your graft down, and now it's time for the hemostatic layer. How do you make sure that hemostatic layer is hemostatic?
Well, that's where you slow down and do it right. So, as you say, we've passed the 3 sutures that are subannular through the bottom of the graft, which, by the way, we shorten. The graft comes much longer than you'll need it, so we shorten it to about 2 or 3 rings at the bottom and about 5 at the top. And it also helps if you get out a marking pen and put marks on the graft. The graft has 3 marks on it, And we take the marking pen and subdivide each of those 3 areas in half, which helps you line up the coronaries and such. But we shorten the graft to 2 rings at the bottom, about 4 or 5 at the top. We lower the graft and tie the bottom sutures, and then fix the commissures of the valve to the sinutubular ridge, and that's usually a pledgeted 4-0 proline. And then we start, as you say, with the hemostatic suture line. Lots of different ways to do this. We find that it's easier to start in the left sinus, then do the non-coronary sinus, and finish with the right. It's interesting, the non-coronary is always the easiest one. The right is always the hardest, and left is somewhere in between. But we do the left one first, and we start at the bottom of the sinus, taking a good bite of that little sinus remnant, and ideally a little bit of the annulus, and sew inside the graft an over and over continuous suture, come all the way up to the top of the commissure, and then pass the suture outside the graft. These operations are a lot more fun to do if you can do it with someone else who can do his or her side of the graft. Otherwise, there's a lot of backhand sewing that's tough. It really becomes a joy to do it with someone who can really do half of the operation with you. So you do your half of the left, he or she does his or her side of the left, and then go around and finish the other sinuses. And then all those sutures are tied outside the graft.
What size sutures are you using?
It's usually a 4-0 proline with an RB1 needle.
Yeah, great. And do you use any glue in addition to that, or just doing it properly is going to stop it bleeding?
Well, of course, doing it properly will stop the bleeding. People usually ask me about this question about glue, and I say that I really believe that the use of these glues is the mark of a mediocre heart surgeon, and I use it all the time. And so, but not at this stage. I think it may have a role toward the end of the operation to stop some of the needle hole bleeding around the coronaries, and maybe to some extent at the base of the graft, but not on the inside.
Yeah, and positioning the coronary buttons, you've got your lines, haven't you? And
yes, and actually the lines are not so much to help you. I should have been a little more explicit about this. The lines that are already made on the graft, they line up with the commissures, and there's one line which is much thicker than the other 2, and by convention we just put that at the anterior commissure. It's nice if you have these routines. They're pleasurable in and of their own, but they give you checkpoints along the way that I think help make this a safer, more reproducible operation. So we always put that heavier seam anterior, and then those marks that are subdivided, they're actually not so much for the coronaries as they are the subannular sutures, which are going to be halfway along the sinuses. So we've now tied in the graft, we've run our internal suture line, and sometimes we have to go back and put in an additional mattress suture if there's a little fold of the sinus remnant, because that's where the leaking or bleeding will occur. It'll come down between the graft and the aortic root. So you want to go back and check that suture line, put some additional sutures in if there's a little fold. And there's a little trick which I really find difficult to explain or illustrate, but as you're sewing on the inside from the bottom of the sinus up, there's a way to pull the commissure up a little bit and kind of straighten the graft and that line of tissue out, so that instead of sewing along a curve, you're really just sewing a straight line up. But once you get the hang of that, this operation really sets up nicely. So left coronary, there's usually not a lot of thinking about this. It just goes dead middle of the left sinus, and it's usually about halfway up the height of the sinus. Better, I think, to have it a little bit on the high side and under a little stretch than to have it too low, and that's particularly true of the right coronary. We use a 4-0 proline and a little strip of Teflon felt, which has reduced the risk of late pseudoaneurysm in our series. So I don't apologize for the felt. I do apologize for the glue, but I don't apologize for the felt.
You make a little round disc of it, do you?
We used to make them. We used to call them lifesavers. We cut a nice little circular ring because they look like the American candy, lifesavers, and that's also what they do. But we found if you just make a linear strip, it actually is easier because the lifesaver keeps rolling up into your field. So just a nice narrow long strip and just set it down. We do every end-to-end anastomosis at Hopkins the same way. I mean, it's just it's boring, but we always start 180 degrees apart, away from where you're standing. So if you're sewing 2 tubes, you start 180 degrees away, which is usually about here. Pass one end inside out through the aorta and tag it, and then you just start sewing on the inside continuously. And same even with these coronaries, even though it's not strictly speaking end to end. And come all the way around and tie it, check to make sure that you don't have a problem with the coronaries, probe it when it's done. One little technical caveat is that you will occasionally see coronaries that kind of come up vertically, and there's a shelf there of the inferior rim of the ostium, and then you got your whole button up here. If you preserve too much of that, if you make the bottom part of the of that coronary button too big, that will be a flap valve under pressure. And we've seen a couple of times we took the clamp off and the coronary didn't perfuse, and it was because that inferior rim of the coronary ostium was pushed back and occluded the left main. This is illustrated in one of our papers, I think, and the solution is to make the inferior rim of that button fairly narrow, so you're sewing right to the rim of the opening of the ostium. So that's the left coronary. That's usually the easy one, and as I say, right in the middle of the sinus. And then we tend to do the right coronary artery next, rather than putting the aorta together, taking the clamp off and finding the right place for it, as you might say with a Bentall or another operation. I'm terrified about making a hole in the graft not knowing where the aortic valve is. Sometimes the leaflets get stuck up against the graft, and if you make a blind hole in the graft, you can potentially injure the valve. So the position of the right coronary artery, that's always the Achilles heel of any root replacement. That's where you run into your problems. So in a valve sparing, it's almost always the same place. It's the anterior corner, or the anterior part of the right sinus, and it's just underneath the sinotubular ridge of the graft. So if the sinus in that graft is a half moon, it's the anterior part right up at the top. And just put it there. And if the coronary is mobilized widely, that'll work just about every patient. And we sew it in the same way as the left.
Fantastic. And then, so you've done the proximal anastomosis and then the distal anastomosis. I suppose you do just the same as all the others, 180
That's right.
degrees away.
Start 180 degrees and sew to yourself.
Yeah, and you just do a single layer, do you?
Single layer, and we do use a felt strip on that one too. And then we'll often use the bioglue there, although I'm not sure I'm doing the right thing.
That's the best way to make sure that doesn't bleed, eh? That
Well,
can be a pain in the
bioglue helps small holes seal faster, but the price you pay is perhaps obscuring the big holes that you wish you'd put a stitch in a couple of years later.
Yeah, fantastic. Well, that's a great insight into your technique, and in your experience, do you get many late problems? If you stick to that technique, then you shouldn't get too many late problems, because obviously these people are going to be alive for a long time, aren't they?
It's worked well for us. So the series with the technique that I've just described has really gone very well for us. We've not had any reoperations for aortic insufficiency. But again, this technique only goes back to 2002, so we don't have 15-year follow-up on this. But it's clearly doing much better than the old Yakub operation, which doesn't stabilize the annulus. And in the Yakubs that we did, a lot of them were already splayed out and leaking 3 or 4 years down the line. So this operation clearly is a better operation for Marfan syndrome.
So So I just wanted to ask now on a slightly different topic, because that's been brilliant insight to the elective condition, and we've all got to try and do these electively. But the thing that really brings me out in a cold sweat is maybe being on call one day, and you not only get the phone call from an aortic dissection, but you come and see the patient. He's tall, he's thin, he's got a huge arm span and a high arch palate. What's your advice to a surgeon out there who's not as expert as yourself? He sees a Marfan's dissection. Should they do anything different to their routine operation? What should they do?
Well, if the question is should they try to save the valve, all I could say is don't let that patient be your first valve-sparing route. I think you need about 20 of these elective procedures under your belt before you really think about doing it in the emergent situation.
Would you always try and get rid of the root, though? An interposition tube graft, is that acceptable? Or?
Very good question. If you really do believe that it's Marfan syndrome, you must replace the sinuses. There are a couple of patients out there that dissected with very small sinuses that on follow-up the sinuses didn't dilate much, but most of them you really do need to replace the root. And again, I think the Bentall is probably the safest operation in the setting of an acute dissection for Marfan syndrome patients, unless you've already mastered the valve sparing. I can tell you that when I go into the operating room with an acute type A dissection in a Marfan patient, my plan is a Bentall, and I can be dissuaded if I don't have any concerns about malperfusion, or if things are going well, that the stars are aligned for a nice, quick valve sparing, we'll do it. And we have done it a handful of times. Our practice is largely aortics, though. We really don't have a lot of acute dissections in our series, as large as it is.
And just in that acute aortic dissection, how far distally would you go in the acute dissection situation?
We would stop at the anominate artery. Unless there were malperfusion associated with arch tears, we stop. I mean, this is not a curative operation. This is an operation to prevent intrapericardial rupture, loss of aortic competence, and coronary malperfusion. We're trying to prevent death from those mechanisms, and that can be achieved by a graft that stops at the anominate artery. And then if the arch or descending aorta needs work, that's for another day.
Yeah. You got any good tips for stopping that end bleeding as well with a dissection? Do you use one layer 4O Teflon or with some glue?
If it's friable, or if the dissection is sort of more than a few hours old, we will actually use two layers of felt, one on the inside, one on the out, and then actually complete that suture line with a continuous proline before we sew the graft to it. Really make sure that you're happy with that. Don't try to do all of that. Graft, Teflon, adventitia, media intima, and felt is too much for one pass of the needle. I think it's better to get that the distal anastomosis, that reinforced anastomosis, get that right before you sew the dacron to it.
You do Teflon, adventitia, Teflon, get that with a continuous and then put it on.
Right.
Do you put some glue in as well? Or?
Sometimes. I worry about the glue there because you sometimes don't know where it's going to end up. It's ended up in the brains of some patients, and I don't think it really holds. So there's less value in my mind using the glue up in the arch.
Great. Well, that's a fantastic tip. I'll bear that one in mind. And I suppose the final message is really we've got to do these electively, haven't we?
That's exactly right.
And then we'll get safe long-term results in these patients.
Yes. The cat's out of the bag if a dissection has occurred.
Yeah, great. Well, thank you very much for this interview. It's been absolutely brilliant. And from myself, Joel Dunning, and everyone at CTS Net, can I just say thank you very much?
My pleasure.
Thank you very much.
Good.
That was brilliant. Thank you very much. That was excellent.